हेलो फ्रेंड्स, तो आज हम निमोनिया के बारे में पढ़ेंगे। निमोनिया में हम पहले लंग्स के बारे में देखते हैं। ठीक है। राइट लंग तीन लोब होते हैं, लेफ्ट लंग में 2 लोब्स होते हैं। और राइट लंग अपर लोब, मिडल लोब, लोअर लोब जैसा कि हम जानते हैं, और लेफ्ट लंग में अपर लोब, लोअर लोब और मिडल लोब को लिंगुला हम इधर बोल देते हैं। राइट लंग जनरली 450 ग्राम्स का होता है एवरेज, और लेफ्ट लंग एवरेज 400 ग्राम्स का होता है। अपर रिस्पायरेटरी ट्रैक में नेज़ल कैविटी, ओरल कैविटी, फेरिंग्स, लैरिंग्स, ये सब चीज़ें आती हैं। और लोअर रिस्पायरेटरी ट्रैक में फिर हमें देखने को मिलता है लैरिंग्स, जो कि ओपन होता है ट्रैकिया में। लोअर रिस्पायरेटरी ट्रैक जो कि स्टार्ट होता है ट्रैकिया से। फिर निमोनिया क्या होता है? निमोनिया इन्फ्लामेशन ऑफ रिस्पायरेटरी ट्रैक बियॉन्ड टर्मिनल ब्रोंक्यूल्स। दिस इज द टर्मिनल ब्रोंक्यूल विच इंक्लूड द एसिनस। एसिनस में रिस्पायरेटरी ब्रोंक्यूल आता है, एल्वेओलर डक्ट आता है, एल्वेओलर सैक आता है। इसका कॉजिशन क्या होता है? ये बैक्टीरिया, फंगस, वायरस, किसी भी चीज़ से हो सकता है निमोनिया। अब हम थोड़ा सा इसके बारे में पढ़ लेते हैं। ये एक रफ डायग्राम है, थोड़ा डायग्राम मेरा गंदा है बट दैट आई नो, तो आप लोग को समझ में आ रहा होगा। फिर ट्रैकिया जो डिवाइड होता है ब्रोंकाई में बाइफर्केट करता है, जिसमें कि प्रिंसिपल ब्रोंकाई आती है। फिर ब्रोंक्यूल्स देन आते हैं, इसमें प्राइमरी ब्रोंक्यूल, सेकेंडरी, टर्शरी ब्रोंक्यूल्स। फिर ये जो है लैटरल टर्मिनल ब्रोंक्यूल, फिर टर्मिनल ब्रोंक्यूल से फिर रेस्पायरेटरी ब्रोंक्यूल, एंड देन एल्वेओलर डक्ट, एंड देन एल्वेओलर सैक। और हम इसको टर्मिनल ब्रोंक्यूल के बाद जो रेस्पायरेटरी ब्रोंक्यूल, एल्वेओलर डक्ट और एल्वेओलर सैक आता है, इसको एसिनस बोल देते हैं, ये तीनों को। As you can see, trachea bifurcates into bronchi, then bronchioles, then terminal bronchioles, then respiratory bronchiole, alveolar ducts, alveolar sac, which is also known as alveoli. These three are together known as acinus. Cartilage are present in larynx, trachea, and bronchi. And then acinus, part of lung distal to terminal bronchiole. Acinus is the part of lung which is distal to terminal bronchiole, as you see. Respiratory bronchiole, alveolar duct, alveolar sac, which includes. Then we study about pulmonary lobules. Pulmonary lobule, cluster of 3 to 5 terminal bronchioles, each with its appended acinus, is usually refers to as pulmonary lobule. 3 to 5 terminal bronchiole with its respiratory bronchiole, alveolar duct, alveolar sac. Each they have their own respiratory bronchiole, alveolar duct, and alveolar sac, each terminal bronchioles. Then we study this diagram. We say lobular bronchiole, terminal bronchiole, respiratory bronchiole, then alveolar duct, then alveolar sac. This is one lobule, as you see. Pneumonia. We study 2 type of pneumonia, lobar pneumonia and lobular pneumonia. Okay, lobar pneumonia and lobular pneumonia. In lobar pneumonia, we see that it is of diffuse and continuous, and in lobular pneumonia, here in lobar pneumonia, a lobe is involved, as you see here, a patch. There are a lot of small little patches, as you see in a particular lobe. This is lobar pneumonia. Then we see as here conducting zone and respiratory zone. Conducting zone include trachea, bronchial tree, bronchioles, terminal bronchioles, and respiratory zone include respiratory bronchiole, alveolar sacs. Then alveoli. Alveolar sac are lined by type 1 membranous pneumocytes, 95%, which are, and type 2 granular pneumocytes, which are 5%. Pneumonias is defined as acute inflammation of lung parenchyma distal to terminal bronchiole, consisting of respiratory bronchiole, alveolar duct, alveolar sac, and alveoli. This is the basically inflammation of lung parenchyma, which is distal to terminal bronchiole, that is respiratory bronchiole, alveolar duct, alveolar sac, and alveoli, which is also known as acinus. As we study distal part to terminal bronchiole is acinus. It is called due to pneumonia is caused due to as bacteria, virus, fungi, as we studied earlier. This is consolidation of lung. Routes. Microorganisms enter by one of following four routes: inhalation of microbe present in air, aspiration of food in trachea of organism, um, from nasopharynx or oropharynx, hematogenous spread from a distant focus of infection, direct spread from an adjoining site of infection. Classification based on anatomic region of lung parenchyma, based on etiology and pathogenesis, based on clinical setting in which infection occurs. Then we see in an anatomical basis, on etiological basis, and on clinical basis. Basically, clinical is not that much important as anatomical and etiological are. And in anatomy, lobar pneumonia, which is diffuse type, and bronchopneumonia or lobular pneumonia, which is patchy, and interstitial pneumonia, which involves background of lung. We see mainly vertebrae and that things are involved. Then we see in etiology basis bacterial pneumonia, viral pneumonia, pneumonias from other etiology. Bacterial pneumonia is of maybe of lobar pneumonia type or of lobular pneumonia type, but viral and pneumonia from other etiologies are of interstitial pneumonia. Then in classification we see bacterial pneumonia, which is of lobar and lobular. Lobar pneumonia includes 4 stages, and lobar bacterial pneumonia includes one stage only. We will study it later. Viral pneumonia and fungal pneumonia, which is of interstitial type, which involve background also. In lobular pneumonia, as you say, bronchopneumonia, consolidation is patchy and discontinuous. Here you can see patches, and in lobular pneumonia, consolidation is continuous. In bacterial pneumonia, lobar and lobular type. In lobar pneumonia, it is an acute bacterial infection of a part of lobe, the entire lobe, or even 2 lobes of one or both the lung involved. The condition is frequent in adults. Etiology: pneumococcal pneumonia, streptococcus pneumonia, type 3S pneumonia. More than 90% लोबार pneumonia में ये वाला होता है pneumococcal pneumonia. Staphylococcal pneumonia, Staphylococcus aureus, streptococcal, beta hemolytic streptococci, children after measles, and in diabetics. Pneumonia by gram-negative aerobic bacteria, Haemophilus influenza, and other bacteria like Pseudomonas E. coli, Pseudomonas, in children below 3 years of age after viral infection. In children below 3 years of age after viral infection. 4 pathological phase of pneumonia. लिनेक्स ने डिवाइड किया था लोबुलर न्यूमोनिया को 4 सिक्वेंशियल पैथोलॉजिक फेजेस में. पहला स्टेज ऑफ कंजेशन, इनिशियल फेज, देन रेड हेपेटाइजेशन, अर्ली कंसोलिडेशन, then gray hepatization, which is late consolidation, then resolution. Then first we say stage of congestion. There are 4 stages in lobar pneumonia. We are now studying these stages. First is stage of congestion. In a stage of congestion, acute inflammatory response to bacterial infection lasts for 1 to 2 days. Here 1 to 2 days it lasts for. Grossly lobe is enlarged. We see lobe is enlarged, heavy, dark red, congested. Cut surface exudes frothy fluid with blood stain. When we cut the surface, it exudes frothy fluid which have blood stains. Histologically, dilation and congestion of capillary in alveolar wall. Pale eosinophilic edema fluid in air spaces are seen. A few red cells and neutrophils in intraalveolar fluid are seen. Numerous bacteria demonstrated in alveoli fluid by gram staining. So these are the histological appearance. Then we in red hepatization, which is the second stage of lobar pneumonia, which is early consolidation phase. This phase lasts for 2 to 4 days. The term hepatization in pneumonia refers to liver-like consistency of affected lobe on cut section, which means liver-like consistency of affected lobe we see in cut section. Grossly, affected lobe is red, firm, consolidated. Affected lobe is red, firm, and consolidated. We see lung is spongy and liver is stony type, and lung become like stone. I'm explaining hepatization. Lung becomes stony type, so we say it as a hepatization of lung. Then grossly, cut surface of involved lobe is airless, red, pink, dry, granular, and has liver-like consistency. As we here study liver-like consistency, the stage of red hepatization is accompanied by serofibrinous pleurisy. Then in histologically, edema fluid replaced by strands of fibrin, cellular exudate of neutrophils, and extravasation of red cells. Neutrophils have ingested bacteria. Alveolar septa are less prominent. Then third stage is grey hepatization, which is late consolidation. This phase lasts for 4 to 8 days. Grossly affected lobe, firm and heavy. Cut surface is dry, granular and grain appearance with liver-like consistency. Here the cut surface involves lobe is airless, red, pink, dry, granular, and here it is dry, granular and grain appearance with liver-like and has liver-like consistency here also present, and here also liver-like consistency is present. Change in color from red to grey begins at hilum and spread towards periphery. At hilum we see red color, and at periphery we see grey color. So fibrinous pleurisy is prominent here also. Here serofibrinous pleurisy is seen in red hepatization, and here we see fibrinous pleurisy. Histologically, fibrin strands reduce, neutrophils is reduced, macrophages begins to appear. Resolution stage begins by 8 to 9 days. Antibiotic therapy reduces resolution on about 3rd day. When we give antibiotic therapy, then resolution is reduced after 3rd day. Solid fibrinous constituent is liquefied by enzymatic action. Then we will study lobar pneumonia, broncho pneumonia. It only have one stage, as we studied. So lobar pneumonia is infection of TB that extends into the surrounding alveoli, resulting in patchy consolidation of lungs. Frequent in extremes of life, that is infancy and old ages people, we see this. In chronic debilitation disease and as a secondary infection following viral respiratory infections. Then etiology is same but mixed, same as that of a lobar, as we see here. Then here etiology is staphylococcus, pneumococci, Haemophilus influenzae, gram-negative bacilli, Pseudomonas. All these are etiological agents. Grossly, patchy areas of consolidation frequently found bilaterally, more often involving the lower zones. On cut surface, dry, granular, firm, red or grey in color, slightly elevated. These things are seen grossly. And then histologically, acute bronchiolitis, Suppurative exudate consisting chiefly of neutrophils in peribronchial alveoli. Thickening and alveolar septa by congested capillary and leukocytic infiltration. Less involved alveoli contain edema fluid. अब हम इसका डिफरेंस देख रहे हैं लोबार और लोबुलर निमोनिया का। इसमें क्या है, लोबार निमोनिया जो है ये यंग और एडल्ट में देखने को मिलता है, और लोबुलर जो है एक्सट्रीम्स ऑफ एजेस में, मतलब लाइक इन्फेंट्स एंड ओल्ड एजेस में देखने को मिलता है। देन ये मोस्टली ऑर्गेनिज्म इसमें मोस्टली नीमोकोकाई, और इसमें मिक्स्ड ऑर्गेनिज्म, मतलब मे बी स्टेफ्लोकोकाई, स्टेप्टोकोकाई, हीमोफिलस इन्फ्लुएंजी, नीमोकोकाई और सम अदर bacterias. Then crossly lobes here diffused, and here patchy bilateral basal affection of both lungs. Then here type of inflammation here is fibrinous, and here suppurative type, and here 4 stages are involved, here 1 stage is only involved. Then mode of healing here resolution most cases, and here lysis and complication most common. So this is all about pneumonia. So this is basically a short explanation of pneumonia. Now we will study tetanus in next lecture.